I tend to speak differently. I'll project, I speak slower, I enunciate more, and then I have my normal conversational voice.
Yeah.
Should we do more of a public speaking, how I would present a lecture, or just kind of talk as if I'm explaining to my friend in a tutorial session?
Why don't we begin just, you talk how you talk.
Okay. So we have a patient. It's a 70-year-old male with a history of heart failure, diabetes, and renal failure, who presents to the eMERGE hypotensive and tachycardic. His extremities are cool, his JVP is elevated, and chest x-ray reveals severe pulmonary edema. He is diagnosed with acute decompensated heart failure and is rapidly deteriorating. How do you manage this patient? As a resident, this is a completely realistic scenario. You're working likely in the eMERGE if you're in Vancouver, but if you're in Prince George, you're somewhere where there's not big tertiary care centers, you could just be the family doc, you could be the internal medicine person on call. This is a patient who has a few comorbidities. You know, he's an older gentleman, maybe not doing so well, maybe not the fittest, maybe a little bit on the overweight side. You know, his heart isn't working so good, but he's kind of been ticking along. And then, let's say he went to a wedding or something like that, had tons of salt, tons of fatty foods, tons of alcohol, and then he comes in a day later and he can't breathe. So what's happened is his heart can't handle all that increased volume and it's shutting down. He's not perfusing his brain. He's confused because he's losing the blood flow to his brain, so he's kind of drowsy, he's out of it, you know, muttering some nonsense. He looks sick, like he looks unwell. When you see a patient who's hypotensive and tachycardic, the adrenaline kicks in and you don't necessarily feel tired anymore. The main concern is, you know, you curse yourself a little bit and say, oh my God, now I have to call ICU. Because the main thing you have to figure out within the first few minutes of seeing this patient, can I manage him in the eMERGE, or is he going to need to go to ICU and get some more advanced medical support than we can give in emergency? Are we going to have to intubate him is one of the questions. Are we going to have to give him some really potent medications IV that stimulate his heart to work? Are we going to have to give him epinephrine?
So when this patient comes in and I mean, do the alarm bells go in your mind? Do you say, I mean, tell me what goes to your head, but you know, for me it's like, holy this guy's going to die if I don't do the right thing, and do I know what to do? Like, is that something that happens?
That's fair enough. When you hear hypotension and so hypotension is low blood pressure, tachycardia is a high heart rate, it means that the blood isn't going where it needs to be. Anyone, even a third-year medical student, is going to know this is not the guy that you go and get, you know, take your 10-minute break to get food and then go see. You drop what you're doing and you go assess him now.
Okay, so, all right. Well, you've got my attention, so maybe you continue with the script.
Heart failure is one of the most common conditions that you'll see in clinical practice. But to properly treat it, you need to understand how the heart works when it's not failing. From filaments to Frank Starling, understanding the basic science of preload and afterload in a clinical setting. So, as with anything in medicine, let's start with a definition. So this Frank Starling Law that I'm going to talk about is a fundamental relationship in cardiology that you need to be able to recite at 3 in the morning, when you're on call, when you've been up for 30 hours, at any time of the day.
Who's Frank Starling?
So it's actually two gentlemen. I believe it's Otto Frank and Ernest Starling. They were some big-time physiologists somewhere back in the early 1900s. I think they were probably classic Da Vinci men in the old Renaissance type. They were scientists, probably gentlemen scholars, high starch collars. And they did some different experiments with frog hearts and dog hearts and things like that, and somehow came up with this relationship. And it's just an observed relationship, which we actually went down and figured out why it works. But at the time, they just kind of noted that the heart has certain properties. So Frank Starling Law states that the stroke volume of the heart goes up in proportion to the end diastolic volume. So if we want to rephrase that, the more you fill the heart, the better it contracts. And it's that simple. Just remember that relationship and you will understand everything you need to know about cardiac function. The more you fill the heart, the better it contracts.
Okay, so the more the heart is full, the better it contracts. Like, why would that even happen?
The answer to that is based on the myocytes, the muscle cells in the heart. The myocytes. So actually, the way a myocyte contracts depends on whether or not you stretch it before it contracts. So when you stretch these cells, two things about them change. Number one, they contract harder, which generates more tension in the cell. And number two is they contract faster. So what we're saying that if you have a heart muscle that is stretched by a greater amount of blood before it contracts, so you have a bigger end diastolic volume, stretches the myocardium, it allows it to contract harder and faster.
So if I wanted to compare this stretching phenomena to something else, I mean, the first thing that pops into my head is, I don't know, an elastic band or a banjo string or something like that. If you pull it back really hard, it's going to twang.
Yep, that's exactly how you can think about it, is that if you stretch an elastic band just a little bit, it'll kind of snap back in a wimpy way. But if you pull something really, really hard, it's going to snap back really fast and probably with a lot of force and can probably hit you if you're not being careful.
This is something I learned when I was an 8-year-old and I had a 10-year-old brother.
But the analogy of the rubber band also extends to the fact that if you stretch it too much, you can break it. There's a finite point at which stretching equals better function. And that's the same thing in the heart. So like I was saying, you get this relationship between the amount of blood you have in the heart before contraction and how well it can pump. So ergo, you get the Frank-Starling curve. Now the question is why? Why do the muscle cells react to stretch in this way? And the answer to that is cross bridges. What is it about cross bridges again? Something about actin, myosin. I think calcium's in there somewhere.
Yeah, I'm actually thinking, I've never heard of cross bridges at all.
Okay.
Maybe I was sick.
So to explain how these wonderful things called cross bridges work, we are going to refer to our preeminent experts in the field, Dr. Ed Moore. So Dr. Moore, can you tell me, how exactly do cross bridges work?
Cross bridges. If you remember from lecture, the cross bridge is the head of the myosin molecule, and it will bind to the actin filament. Once calcium is released from the sarcoplasmic reticulum, it'll bind to troponin. Troponin will undergo a conformational reorientation that will in turn have tropomyosin undergo a conformational reorientation and move within the groove of the actin filament, unmasking the myosin binding sites or the cross-bridge binding sites. It then undergoes cyclical attachment and detachment, bringing the sarcomeres together and shortening the muscle.
If you could compare cross-bridge cycling...
Rowing. Yeah. In fact, when I actually give the lecture, I give them a visual demonstration. And I go, because the cross bridges do this, they go up, they attach, and they pull, but I tell them it's not like rowers going, like a group of 8 all going together. They are all going independently from each other. But it's like they're rowing.
So is it, one on the left side and the next one down on the right side, and then does it run sequentially like that? Or
there's a filament, and the way the myosin molecule is put together is this is the thick filament, and it's a polarized molecule, so at opposite ends there's the myosin heads stick out, and they reach up and they grab onto the actin filament and they pull on the actin filament, and this half is pulling this way and this half is pulling this way, so the ends of the muscle come together.
Who's calling the rowing?
Nobody. They're kind of working independently of each other, but the coxswain here is the calcium ion. Until he comes out and says, begin, they may not begin. And when he goes away, they stop.
Now that the visual idea of actin and myosin is fresh in our minds, we can talk about why the contractile properties of muscle cells change with stretch. Essentially, the pre-contraction length that's going to generate the most force the fastest, that ideal length is based on the overlap of the actin and myosin filaments. So too short, and there's no shortening left to do. But if the stretch is too great and the filaments are not close enough together, there's no way for the myosin to grab hold of that actin. So the increased force can be explained by the geometry of these two filaments overlapping. Unfortunately, the increased velocity is not as well understood.
So what is this? What do you call this?
So In clinical terms, because we need to redefine everything from physiology to the clinic, we refer to this pre-contraction stretch as preload. So we can think of preload being synonymous with the end diastolic volume. It's just a term that we use clinically to indicate the amount of stretch on the heart muscle before it contracts.
So preload is stretch?
Yes.
Okay. I'm a little bit overwhelmed. Can you kind of sum this up?
Mm-hmm. So we have our muscle cells, and they contract harder and faster when you stretch them beforehand because all the filaments get properly positioned or something like that. So we preload the heart with extra blood in diastole, and then we get more blood out during systole. And we call this relationship the Starling Law of the heart.
Okay.
Good?
I'm with you. Let's go. I'm ready.
Okay. So we know about preload. Is there an afterload? Well, of course there is, because we have pre, we have to have after. So historically, the name came about because it refers to factors that the heart muscle can only sense after it's begun contracting, hence the after part. Versus preload, which is stretch. It's something that the heart muscle can sense before it begins contraction, hence the pre part of that term.
Okay.
It's a good way to remember it.
Mm-hmm. So before contraction, after isn't after it contracts, but after it begins contracting. From that point forward is after.
Yeah, pre and after can be thought of in terms of the start of contraction. What is afterload? Okay, so afterload is defined as the wall stress in the ventricle during contraction. As the wall stress in the ventricle during contraction. Afterload, which kind of begs the question, what the hell is wall stress?
Yeah, what is wall stress?
So we know that when the muscle is contracting, there is a certain amount of force or tension in the muscle cell. So wall stress, quite simply, can be thought of as the tension in any one myocyte or muscle cell during contraction, and it is that simple.
I don't understand.
So let's go back to our basics. You have a muscle cell, right? Let's fix it at both ends and get it to contract. If you don't allow it to shorten, that contraction generates tension in the muscle cell. Tension that's going to be held in all those ratcheting cross bridges. It's like when you're trying to lift a super heavy weight and you just can't do it, there's tension in your arm because you're trying to lift this weight. So when you think about it, contraction in a muscle cell fundamentally equals the generation of tension. Now, to go back to physics for a minute, we can say that we have this tension and it's a vector that's running longitudinally within that muscle cell. Now, if we release the fixed end, the contraction causes the muscle to shorten. And as it shortens, it maintains the tension that was generated right before it was released. Now, this idea of maintaining the pre-shortening tension is pretty important. So pause and take a moment to think over that concept before continuing on, if it doesn't make sense right away.